to start these. If you can't find any that are 3 dots or higher, usually you can, but they're going to need a central line or something else going on. OB space is the only one really I can think of, and even then you could find them usually right in the AC. That's the last place we want to go, but if you have to, that's where you want to start it. So adjusting your image for best results. The gain is where it brightens or darkens the image. You turn the knob one way or the other, it gets brighter or darker on the screen. Adjust the gain back and forth while visualizing the ultrasound vasculature. You want the vein to be dark as it can be and everything else to be light. If you turn the gain all the way up, the vein itself will be white with everything else. So we'll look at that in a second once we see the machine. And then the color setting helps determine veins from arteries. When compressing, the vessel doesn't distinguish the two appropriately. So with hypovolemic patients that have weak vessels for some reason, if you compress, we'll go over compression, but if you compress the vein and artery, the artery should stay patent and firm. The vein should collapse, but sometimes if they're hypovolemic, both of them will collapse just as easy. So the color setting will help determine between the two, and we'll look at that and how to see the pulsating artery versus the smooth flowing vein. And that's what I'm saying. Color setting shows the pulsating in the artery while the smooth, consistent flow remains through the vein. Any questions on gain or color right now? All right, good. So a vein consists of 3 layers. Catheter must penetrate all 3 layers in order to properly thread into the vein. And I put this on here because another issue we run into is you get into the vein on the machine, you see it in the vein, but that's just the needle tip in the vein, and your catheter's still on these 3 layers on the outside. So you get in the vein, you say, okay, I'm good. I go to thread, and I meet resistance. That's because your catheter itself is still in the outside of the vein, the wall. You should, once you see it in the vein, follow it in the vein a few more steps before you try to thread. And that'll help prevent you from just trying to thread it into the outer wall of the vein vasculature. This is some vessel selection tips here for when starting the process. So you want to start distal to the AC and work proximally. So the first place you want to look is forearm. That's where we always start. If you see a great vein there, great. Start it in that vein first, and then work medially. Even with CTAs, you got to put some contrast through there. You can still start at high forearm because the tip of your needle, so these needles are so long that it'll be in the AC, and they should be able to inject it still for the CT chest angio. So forearms first. You got cephalic and basilic vein there. Both of those are usually away from the artery nerve complex. And then upper arm next, cephalic and median veins are the choice, or basilic and cephalic in the upper arm. So you have basilic here and you have brachial on the inside of your arm. Brachial, they say, is last resort. They don't want you starting one in the brachial vein unless it's the only thing you see there. That'll be with a whole plexus, brachial plexus of stuff. It'll have a vein, artery, and a nerve right there in one spot, and that's how you know it's a brachial vein. And that's usually where you start PICC lines in the brachial vein. But we use basilic first and cephalic if you can find it up on the top of the bicep. Either one of those are good choices first. And then you can always look in the AC. If you do look in the AC, you can sometimes track it down toward the forearm with the probe and then start it in the forearm, or you can track it up in the upper arm and start it, but it may get deep up here, it may be deep down here, depending on how big the person is. So AC, if you have to, you can always put it there as a good choice. But just the brachial vein is the last choice, just because it's close to everything else there. And you may see patients come with ultrasound IV started here. That's usually basilic vein and not brachial. But sometimes it may be brachial vein, just depends on what they found when they were looking. So this is the cross section here of the upper arm. So here you got the brachial complex, 2 brachial veins They'll come together eventually in the upper arm, but this may be kind of close to the AC. They'll start coming together and joining in one big brachial vein, and then your brachial artery. These won't be colored on the ultrasound machine. I just colored them so we can see everything. Brachial vein in the middle. We'll be able to determine between these when we look at the screen. And then your basilic vein's way over here by itself. That's the best choice. If you see this on the screen, this will be your best choice to go to. It's most superficial, one, and it's away from all this stuff. And then this is a nerve, brachial nerve. Well, it says artery, mislabeled, but brachial nerve here has a honeycomb appearance, is what they say. It looks kind of like a bundle of, like a honeycomb on the screen. And we'll try to locate that too. Sometimes those veins or nerves are hard to find, but that's your big nerve there. And we'll go over, if you start hitting a nerve, starting IV later on this PowerPoint, how you know that you're touching the person's nerve or stabbing the nerve. You don't want to do that. It hurts a little bit. So tips when choosing the vessel: you want to avoid areas of flexion, avoid the AC, but if you have to, like I say, you can always start it there. And like this is what I was saying, you can scan more proximal or distal to the AC to try to get you a straighter area of insertion. And then use warm packs on extremities if they're cool to touch. That'll also help make your veins bigger. Avoid areas where nerve bundles are present, such as that brachial area. And compress the probe as you scan to discern veins from the surroundings. And more on this in the next slide here. So this is what it'll look like once you push down on the patient's skin with the probe. Artery, vein, and then your vein collapses when you press down with compression. So that's what the vein should look like once you compress. And like I say, if they're hypovolemic, both of these will be collapsing, and you have to use the color probe to color option to determine between the two. The artery will, if you hold mild compression, just collapse the artery just a touch, you'll see the pulsating artery on there, and then the vein will collapse easily. And then hypotensive, severely dehydrated patients, the artery may collapse too. Let's see if I can get to something here. I had some videos, but this doesn't connect to the internet, so let's see if we can get it to come up on here. We'll go to the next slide when it comes up. So this is a catheter selection. I'm going to pass these around, let y'all look at them. Ultrasound catheter is a lot longer than the normal catheter length. You want to ensure, this ensures that one half of the catheter resides in the vessel after insertion. 18 gauge catheters with a length of 1.88, which are these longer ones, should be used for all ultrasound guided IV insertions. And this, just disclaimer, unless the ultrasound is only used to locate a superficial vein, in the example below, you can use a regular IV catheter. So if your vein is right here on the top of the screen, you can use a normal size catheter to get to that. But anything below that first dot, 0.5 centimeters, you want to use the ultrasound guided catheter. I'll pass them around, you look at them if y'all haven't seen them before. That's the normal one versus the longer one. So like I say, if you're looking in the form and you got a vein right on the top of the screen, you can always use a normal size catheter and just thread it in there. And that's what we call ultrasound assisted cannulation, not guided. Screen ain't popping up, so sorry. We'll look at it a little bit later. This next slide is showing your angle of insertion. So to answer y'all's question, 45 to 65 degree angle is used. That's a lot steeper than we normally think of, and we'll see a picture in a second of that angle. So 45 to 65 degrees is pretty steep. A lot of nurses, when you first start out doing this, don't like that kind of angle, but again, it ensures that half the catheter is threaded into the vein once you get to it. If you go at a normal degree and you get down to the vein, you only have this much, catheter left to thread, it's going to extravasate. You don't want to do that. If you you're almost to the hub and you're almost to the vein, you definitely want, pull it back out to the skin almost, and then start at a steeper angle. The other thing is, if your angle's too steep, greater than 65 degrees, if you try to go 90 degrees straight down, once you thread that catheter in, it could kink right there at the skin. So you may have a kinked catheter if you try to do it too steep. So 65 degrees, and you'll get used to the angle as you do it. So too small of an angle, you'll get all the way to the vein and not have enough catheter to thread. Too steep, you can kink the catheter once it's threaded in the vein, and it won't flush or pull back blood or anything. So some pictures I took here in the ER the other day, just trying to give y'all some techniques of, when you first start, how to track the vein. So this is just showing, I took a blunt tip pen without anything on it and just put it on the skin wherever I wanted to mark it. Held it for 30 seconds. When you take it off, you got a good mark there. Then you can clean over top of it and everything and still use it. So once you locate a vein, you hold your probe there, you mark the skin right over top of the vein with your pen. You follow your vein up the arm on the screen, center it again, and then mark the next one.